Start now. So good evening, everyone. On behalf of ACHSC and the UCCC team, a big welcome to UCCC 2020 Finalist Night. My name's Jess, and we've got Aisha in the Zoom as well, and we're the co-directors of UCCC this year. Before we start, we would like to first acknowledge the Wurundjeri people who are the traditional custodians of this land. We would also like to pay respect to the elders, both past and present, of the Kulin Nation, and extend that respect to other Indigenous Australians present.
We would like to start by thanking our partners, the Victorian Comprehensive Cancer Centre, the Melbourne School of Population and Global Health, the Gene Technology Access Centre, the Walter and Eliza Hall Institute for Medical Research, Cancer Council Victoria, the Olivia Newton-John Cancer Institute, Tour de Cure, Breast Cancer Network Australia, and the Australian Cancer Survivorship Centre. This year, the theme was cancer survivorship, and the case challenge was to design and propose an updated model of care for Australian cancer survivors. We would like to thank and extend our congratulations to all teams that took part in UCCC this year. We had 66 submissions, all of which analysed cancer survivorship from a unique and interesting perspective, and came up with novel strategies to improve the current model of care for cancer survivors. We very much enjoyed and were enlightened by all proposals, and choosing 5 finalists out of all the submissions was indeed an incredibly difficult decision. I will now pass on to our logistic officers, Amy, Oscar and Minji, to run the night.
We will now introduce our expert panel of judges tonight. Many of you would have heard from them during Info Night. They are Professor John Emery, Professor Michael Jefford, Miss Michelle McIntosh, and Ms. Meg Rinderman. Professor John Emery is the Herman Professor of Primary Care Cancer Research at the University of Melbourne, and he is the Victorian Comprehensive Cancer Centre Primary Care Research and Education Lead. Professor Michael Jefford is a consultant medical oncologist at the Peter MacCallum Cancer Centre, Professorial Fellow of the University of Melbourne, and Director of the Australian Cancer Survivorship Centre.
Michelle is an accredited exercise physiologist. She is the facilitator of the Cancer, Wellness and Exercise Program at Goulburn Valley Health. And finally, Meg is a consumer advocate for the Australian Cancer Survivorship Centre at Peter MacCallum Cancer Centre, and she is a Cancer Connect peer support volunteer of Cancer Council Victoria. We're now pleased to introduce the 5 finalists of UCCC 2020. Climbing Out of Cancer, CAVE, Sharing is Caring, Transfer of Trust, and CanCare, who will present in the order shown in this slide. Without further ado, let us welcome Climbing Out of Cancer to present their proposal.
Thank you. Would I be able to share screen? Yeah, perfect. Thank you so much. That all good? You guys can see that?
Yep, can see it.
Thank you. Congratulations, they all say, as you leave the chemotherapy ward for what you hope is the last and final time. Your oncologist shakes your hand and says, "This is it. You have won the battle." But for many people, their war against cancer is far from over, and their journey as cancer survivors can be immensely rocky and difficult. Ladies and gentlemen, our team can only imagine the immense hardships cancer survivors have to face. But the data shows they can face immense medical symptoms such as nausea, vomiting, fatigue, and pain. They can face an immense fight within their minds, battling feelings of anxiety, isolation, and depression. They can face immense financial strains and find it difficult to return to their jobs. What our team proposes today is a 4-part model called Climbing Out of Cancer. It aims to deal with what we think are 4 important domains to help cancer survivors. Each domain is a flagship program with a number of initiatives which we hope to go through today. Through CanCare, we hope to care and look after a cancer survivor's medical symptoms and their medical journey. Through CanAid, we hope to help cancer survivors facing immense financial and employment difficulties. Through Can Mind, we hope to help cancer survivors' psychological and mental well-being. And through Connection, we will connect and empower cancer survivors, giving them an opportunity to bridge the gaps of isolation with the power of their story and their advocacy. And with 91% of Australians using a smartphone, we have based a number of our initiatives to be delivered through a smartphone app.
So to begin with Can Care, both cancer survivors and GPs often note feeling lost in transition or disconnected as they move from specialist oncology services to the care of their GPs. This is especially an issue because this period is a vulnerable time for cancer survivors physically. Our team's Can Care aims to address this. It aims to empower both GPs and patients with the tools that they need to effectively monitor their well-being and symptoms. We do this in a few ways. Firstly, for GPs, we propose a standardized nationwide assessment tool integrated into GP practice software. This tool will screen cancer survivors for a number of issues with a focus on their physical symptoms. It will allow GPs to identify patients who require oncology referrals earlier and more easily. The second is an app-based system to educate survivors and also allow them to record their symptoms, making note of a particular nauseous morning or a painful night. If there are any alarming symptoms, the app can automatically prompt them to seek help. These diary entries can then be packaged as an investigation result and sent to the GP. From there, it's as easy as the GP sitting in their clinic, opening and reviewing these results, just like they would look at a blood test.
Next is CanAid. It is estimated that cancer can end up costing a household an average of $50,000 per person, and 46% of cancer survivors are unable to return to employment after a cancer diagnosis. CanAid aims to ensure that cancer survivors are financially supported, encourage an early return to work, and to simplify the process of accessing financial and practical assistance. To do this, we're proposing a centralized financial aid search tool delivered through our app. Currently, financial assistance is fragmented and offered by many organizations. This is a process that's both complicated and overwhelming. Our search tool will streamline the search for organizations which may be to assist them in domains such as medical equipment, housing, meals, and more. Secondly, cancer survivors are about to face a tricky situation. Many of them do not qualify for the National Disability Insurance Scheme, and from September, the Australian government is ending the sickness allowance, which many survivors have been accessing previously. Our team proposes a twice-a-year $300 hardship payment. This is for cancer survivors who must take time off work due to their illness or appointments related to their cancer. This is for times when they're ineligible or have exhausted their sick leaves. This will ensure that cancer survivors do not fall through the gaps of our existing support schemes.
Moving on to Can Mind. Cancer survivors are twice as likely as non-cancer patients to experience psychological distress and may feel lost post-treatment. Can Mind has three aims: to recognise mental distress early, to expand psychological services, and to create a personalised mental health care plan. Our proposal expands mental health services by providing all cancer survivors 3 free visits with a trained mental health nurse within the first year post-active treatment. In the first session, the survivor meets with the nurse who assesses them, and together they develop a mental wellbeing plan. This will be followed by check-in sessions that can prompt early GP referral if required. Our model also includes a cancer survivor telephone hotline and 2 subsidised visits for carers. Secondly, our app provides survivors a self-reported screening tool to monitor their mental wellbeing and direct access to their crisis plan. For GPs, we're creating a universal mental health assessment tool to identify at-risk patients earlier and more consistently.
Connection. Cancer survivors frequently report feelings of isolation and loneliness. But at the same time, we know that cancer survivors are some of the most powerful members of our communities. They often have a desire to share their incredible story, which is a story from which we can all learn and benefit. Our Connection program aims to connect cancer survivors with one another and also provide formal opportunities for survivors to engage in advocacy and work in the cancer space. We do this in 2 ways. A live chat function. App users can connect with other survivors and share their stories with one another on an online platform. Secondly is our Connection peer workforce. This is a structured workforce consisting entirely of cancer survivors. It will offer a range of paid or volunteer positions in the cancer space. This may be roles like speaking engagements at schools and community events, social work on oncology wards, administrative duties at screening clinics, or roles in clinical trials. Connection harnesses the spirit of advocacy of cancer survivors and also provides structured and relevant employment opportunities.
So the implementation of our model is staged within 3 key phases. The first phase will focus on the application development, which involves key engagement with both designers and software developers. This is then followed by engagement with health authorities, governments, and clinicians for both program and policy development. And the final phase will involve reaching out to consumers directly and ensuring that they are both engaging and benefiting from this model of care. We have allocated $1 million of our budget to help develop our app, the content, as well as our assessment tools, a further $1 million to develop our connection workforce and Can Mind Cancer Support Hotline, and the bulk of our budget, $3 million, will go towards setting up the infrastructure for our mental health service expansion, as well as the implementation of the CanAid program. We will also require ongoing support from Treasury. We believe that this is a sustainable and a financially viable model, as it only requires an upfront investment in terms of application development. And by getting survivors back to work and decreasing their disease burden, we will ultimately save our healthcare costs and help support our economy.
So, what outcomes do we expect from the implementation of these 4 programs? We expect improvement in physical and mental well-being through early detection and management of symptoms and increased peer support. There will be decreased financial stress through our peer workforce and financial aid services. There will be an increased collaboration and connectivity between cancer survivors, and importantly, an overall improved quality of life for our survivors. We can measure this impact through direct feedback from consumers and clinicians, as well as by doing a longer-term population study. For example, analysing the rates of mental health disorders amongst cancer survivors, or by analysing the number of cancer survivors that return to work earlier.
To ensure our model is watertight, we've looked at some potential risks, limitations, and challenges, and how we plan to address them. This includes the risk of patients becoming over-reliant on the application for management of their symptoms, which is why our app will include alert messages if the patient is reporting red flag or escalating symptoms. We aim to address uptake of the app and tools through education sessions for GPs, as well as having an illustrative and simplified user interface. Lastly, we believe we can tackle the challenge of having to continuously update our app through volunteer support from Connection, NGOs, as well as ongoing user feedback.
Ladies and gentlemen, to wrap up, if we think about a 52-year-old breast cancer survivor and single mum, Sarah, from Shepparton, who resigned from her retail job prior to starting chemotherapy. If we think about Sarah's situation, which is not too dissimilar to what many cancer survivors might have to face, we realise how important it is to have a robust support for cancer survivors. In this task, our team was asked to develop a nationwide, comprehensive model of care for cancer survivors. Under our model, we believe people like Sarah benefit. They benefit through Can Care with better GP support. They benefit through CanAid with better financial support. They are looked after psychologically through Can Mind and are never left to fight alone through Connection. It is our team's collective vision that our model is accessible, is patient-centred, and will empower cancer survivors in climbing out of cancer. Thank you so much.
All right, thank you, Climbing Out of Cancer. We'll now pass on to the judges for some Q&A time.
So, shall I start? Well done. Quick question. So a lot of this relies upon people having a smartphone and interacting with it. I guess that you've already suggested that not everybody does have a smartphone, but one issue might be after people have finished their cancer experience, they may not want to be regularly logging onto a smartphone and recording symptoms and well-being and searching for things. How will you get people to really engage with the smartphone app?
So I think what we thought about when implementing this model is that we would love to have on the final day when you're getting ready and doing your discharge plan with your oncologist, for the oncologist to sit down with the cancer survivors and tell them that if you would like, we do have this application available for you to really give you the power to control your cancer survivorship journey. So that if you are fearful of having your recurrences, this is your sort of security net to know that if you monitor your symptoms through this app, then you have comfort in knowing that your doctor will get regular updates. And I think that's why some cancer survivors may be more likely to actually do this. And with 91% of, I guess, the population having a phone, and I believe we had a look in some research, and I think there's a 42% increase in medical apps over the last decade. So I think it goes to show that people are engaging with these kind of apps. And if by having an illustrative interface, by sitting down with these patients and their carers, that we should be able to get people to really engage with this. And I guess for the patients that do not really want to use the app, this is why our CAN care assessment tool is crucial, because it's going to be an alert on the GP system at 3 months, 6 months, and every 6 months after that to make sure that they are picking up these patients and asking them questions about their symptoms and how they're going.
And can I just chime in with one thing as well? When we were designing the sort of the patient reported aspect of it, we did think that a lot of patients might not be interested in doing that, especially after they've been through such a big journey. But then we sort of realized, and when we had a look at the research, we sort of realized that patients who are experiencing those physical symptoms, who are experiencing the nausea and the vomiting, they're the ones who want to sort of seek help for it. And that puts them in a position where they're likely to engage in in that sort of self-recording tool, because they realize that it can be such a powerful adjunct to the GP's assessment. So we thought, because of the patient population, the people who are likely to benefit from it are the ones who are likely to use it, whilst the people who aren't experiencing those symptoms aren't likely to use it. But that shouldn't matter too much. As long as we're catching the people who have that high burden of symptoms, then that's where we were sort of coming from. Yeah.
Can I ask a question? I'm wondering how you will deal with people whose first language isn't English. My sense is that your app and your initiatives rely on English being the spoken language, and some level of health literacy in general from your patients may not always be the case.
Certainly. So in regards to that question, we've done some search, and it turns out the most spoken language in Australia is English, Cantonese, and Mandarin. So as a start, we will ensure that the app will be covered in those 3 languages.
Okay.
And also especially for those who might be visually impaired, we will have text-to-speech and speech-to-text function on the application to ensure that they will not be discriminated.
Okay.
And on top of that, anything else that you'd like to go build on, guys?
Yeah, I might just quickly add one other thing as well, and also with that sort of community aspect about, non-English speaking sort of patients and that patient population, what we can do through our connection program is actually sort of foster links between specific communities. So for example, if there's a population of Maltese women who are suffering from cancer, and if we've had a Maltese woman who wants to engage in this, for example, then they can reach out to their population, to that cohort. So that will be the beauty of the sort of connection program in terms of the social aspect of, I think, your question. Yeah.
Oh, and just to build on another thing, kind of what Aaron's just going off, we're also thinking of building connections with groups such as Cancer Council Victoria, who have more access to databases that are more with information that are more patient friendly and might involve more lay terms, which will make the information involved on the app a lot more friendly to approach.
Can I ask another question? Congratulations, first of all. It's a really interesting proposal and well presented. Obviously, GP software providers have lots of different app developers coming to them with another really good idea. How are you going to persuade the software providers why they should spend time integrating this tool as opposed to several of the other apps that other people are knocking on their doors saying this is the best thing since sliced bread?
So we believe that our app is superior to the other apps on the market, the main one being Cancer Aid. Our app is the other apps have been global, where they've served populations in Australia, the UK, and America, whereas our app is going to be focused mainly on Australians. So they will, cater to needs of the Australian population. Furthermore, our app is going to be free for all patients or survivors, unlike other apps which have a small cost associated with them. Our app is also going to be in multiple languages, which the Cancer Aid app is not in. So our app has a few extra functions, as well as being comprehensive and holistic, that makes it a superior choice to the ones already on the market.
And Prof, Emery, I think just to address the sort of the GP side of it, and in terms of the GP and why GP software designers would want to take this up. When we were sort of designing this, we had to look for some precedents for, how sort of previous software tools have been integrated. And we looked at the Aboriginal and Torres Strait Islander application tool that sort of GPs can use to assess any Indigenous patients. And the uptake of that has been sort of widespread nationwide and has been quite a success because it provides a standardized system for GPs to assess any Indigenous patients, which is why we thought that there was some precedents. There's been some evidence that if there's a structured way for GPs to assess a patient population, they could be quite likely to engage with it. So that was our sort of thinking behind it, yeah.
And I guess why we think that GPs might be open to this new idea is that through our studies, a lot of the GPs reported that they were feeling disconnected. And there have been many articles which have suggested that GPs can actually play a bigger role in the follow-up care. So I think combining all the factors that our team has said, we believe that companies such as Praxsoft and Best Practice will really recognize the importance of having this one universal nationwide assessment tool.
Sorry, can I just to follow up? How do you see this improving collaboration between oncologists and GPs? That was a bit less clear to me.
Mm-hmm.
Yeah, so to sort of in our model, what we're looking to, in the current sort of template of the current model, there's steps 2 and 3, which is end of active treatment leading up to follow-up care through the GP. And what Krisha was sort of getting at is when we were researching, we found that there was a disconnect at that point. So what we're trying to do through the sort of the assessment tool, the CanCare assessment tool, is to try to bridge that gap. We're trying to provide an easy way for GPs to sort of assess patients who have just come from specialist oncology services and sort of understand what's going on in a more sort of systematic kind of way, which we hope sort of sort of smoothens that transition process.
And I think to add to that point, we would really be looking at getting oncologists on board when designing this assessment tool so that we can hear from the oncologist's perspective, what are the things that concern them? What are the things that would want them to sort of ask the GP to refer on even earlier? So that way the GPs have this tool, which has got the input from oncologists so that we can refer at the right time and sort of help bridge that connection.
Yeah. But I think we do recognise to some degree that our model didn't hugely focus on collaboration between GPs and oncologists. And I think one of our research studies that we found showed that GP-led care is not inferior to oncology-led care in certain cases. So that was why we thought, given oncology set up so brilliantly, a lot of our model does focus on empowering GPs and less so, I guess, in an honest way on that sort of collaborative aspect, yeah.
Thank you, Cave. That concludes the question time for the judges. And we're running kind of late, so we won't have time for the questions from the audience. So yeah, thank you for that. And we'll just move on to the next team, if that's okay.
Thank you so much.
Thank you.
Thank you.
Thank you so much.
Yep, and let us welcome next Cave, the next team.
Okay, I think Team Cave has just come back into the main room. Please feel free to start sharing screen when you're ready.
Good evening, judges and guests. We are CAVE, a team of third-year medical science students from UNSW. Our proposal, Survivor Diner, aims to complement and improve current models of care for cancer survivorship in Australia.
Good nutrition plays an important role in the overall well-being of our everyday lives, and even more so in cancer survivors who have different metabolic needs and functions compared to the wider population. In our literature analysis, it was highlighted that poor diets have been associated with increased mortality and cancer recurrence. Additionally, many late common effects of cancer and its treatments were found to be preventable or manageable with nutrition interventions. This demonstrates that focusing on improving nutrition is an actionable target in developing a novel model of care. We have found that there is demand for such a model, as cancer survivors are likely to seek changes in nutrition in order to improve their health outcomes and quality of life. Hence, providing support for these survivors to achieve long-term goals for diet, in addition to fitness and mental health, should be considered in a successful model of care.
Additionally, it is vital that unmet needs are addressed in order to provide an optimal model of cancer survivorship care. Fear of cancer recurrence is a prevalent concern which can deter individuals from enjoying and thriving in life. Moreover, social well-being is impacted as survivors may experience feelings of isolation and difficulty reintegrating back into social environments. This poses a barrier to survivorship engagement. Furthermore, the survivorship phase is a volatile time for mental well-being as individuals emerge out of a stressful period. Some cancer survivors may struggle with emotional adjustments over this period and suffer from anxiety and depression.
We propose Survivor Diner, a free mobile application and website developed in collaboration with healthcare professionals, aiming to encourage cancer survivors to take ownership of their well-being. Our app has 4 sections: nutrition, community, mindfulness, and fitness. The nutrition section is the highlight of the Survivor Diner app, serving as a centralized resource for cancer nutrition.
The community section provides a unique opportunity for users to engage with one another in recipe forums. Survivor Diner is also supplemented with mindfulness and fitness features containing curated resources to promote overall well-being. There are currently no other apps on the market that integrate these 4 features and are available for all cancer survivors, making Survivor Diner a novel model of survivorship care.
Either or both cancer survivors and carers can register to create a user profile. As you can see here, cancer type, treatments, and comorbidities will shape the user's experience on Survivor Diner, differentiating us from other apps. For example, Bob, who had basal cell carcinoma, has undergone these treatments and has these certain comorbidities, will have a recipe feed that is tailored for his profile. Given that different cancers, treatments, and comorbidities can affect nutritional requirements, we have chosen them as significant determinants of a survivor's metabolism and caloric intake.
Survivor Diner serves as a center for nutritional resources catered for cancer survivors. The recipes component offers recipes available for all dietary requirements and displays nutritional information, including calories and macros. For example, a cachectic cancer survivor with chronic kidney disease may require a high-calorie diet with low potassium. Users can learn about cancer nutrition via the nutritionist advice column and FAQs. In addition, a unique feature of Survivor Diner is a paid NutriKit subscription. A selection of meals or a tailored kit can be chosen in accordance with their dietary needs. The ingredients and recipes will then be delivered based off the user's schedule.
Through Survivor Diner, we hope to foster a community for all cancer survivors and their carers. Our platform provides a space for nutrition-conscious survivors to engage with and encourage each other. The community section allows users to reach out to one another by contributing to forums, sharing recipes, and chatting to users. Recipes that are shared on these forums will be vetted by a dietitian and may even be featured in recipes, allowing us to continually expand our collection of recipes.
The mindfulness and fitness sections aim to improve the overall health and well-being of cancer survivors. Our mindfulness activities include daily meditation, as well as long and short-term goal setting, encouraging users to maintain a positive and healthy mindset. The fitness section comprises of daily exercises and activities of varying intensities, along with a tool for calorie tracking. Easy-to-read reports of calorie intake and expenditure can be transferred to the user's dietitian or primary care doctor via the application.
In addition to what we have listed here, we also believe that our model of care can help save time from traveling to in-person consultations and increase access and compliance to professional nutrition advice. Survivor Diner is expected to enhance overall quality of life by developing good nutrition and fitness habits and cultivating a social network of nutrition-conscious survivors. Not only will diet and fitness levels be improved, but silent issues such as fatigue and anxiety can be relieved by our app. This model of care also aims to target the aforementioned unmet needs by providing a supportive environment where feelings of independency, self-worth, and empowerment can be rediscovered. Survivor Diner can alleviate the stress and fear surrounding cancer recurrence by promoting a healthy lifestyle and providing a strong support network.
In the current model of cancer survivorship care, Survivor Diner supports the third phase of follow-up care and monitoring. Survivor Diner complements this by allowing survivors to access helpful resources easily during the long duration between follow-up checkups. Our model of care supports cancer survivor populations that are relatively low accessibility to health professionals, providing nutrition and dietary advice tailored for individual dietary needs. This increases accessibility to health professionals and support from fellow survivors from the comfort of their own homes.
With a $5 million budget and a 3-year timeframe, we have outlined 4 phases for development for successful implementation of Survivor Diner. We will begin with testing the app and website development, which involves researching, prototyping, and testing. The expected timeframe is 6 to 9 months, with an estimated cost of $120,000 based on the current market average. Secondly, to ensure that recipes, information, and resources on Survivor Diner are of the best possible quality, we will hire a team of professionals on a contractual basis for consultation.
The third phase involves managing the supply chain. It covers the costs incurred from renting office and warehouse space, sourcing produce, as well as packing and delivery service for the NutriKits. We estimate logistics expenditure across 3 years to amount to approximately $400,000. The final stage is the Survivor Diner app and website launch. Both the mobile app stores and website require hosting fees. Other expenses are allocated to maintenance, software updates, and marketing. The remaining budget goes towards a contingency fund.
To ensure Survivor Diner reaches the widest audience possible and to combat any accessibility issues, the app is also made available to carers, and it can be accessed without the internet. Offline features will include recipes, FAQs, mindfulness, and fitness activities. For a simple and easy user experience, our user interface is both modern and straightforward, and there will be a tutorial when using the app for the first time.
To ensure that Survivor Diner gains traction in the cancer survivor community, we will seek endorsement from professional bodies such as the Clinical Oncology Society of Australia. Health professionals can also recommend it to their patients. User engagement and compliance may decrease over time, which is why we use app notifications to motivate users to check in on Survivor Diner. The community aspect also encourages active participation.
To guarantee the sustainability and longevity of our app, there will be frequent content updates to sustain interest, which includes new recipes and nutritionist Q&As. Through routine maintenance and implementation of user feedback from the App Store, we hope to maintain user satisfaction. It is also important for us to keep up to date with current market trends to further refine the app. Survivor Diner is potentially self-sustaining as the profit from NutriKit can be used to maintain other components of the app and website.
Thank you so much for listening to our proposal. We look forward to your support.
Thank you, Cave. We will now pass over to the judges for some question time.
Patients' care, and a very strong will be to, I guess, instruct them on how to use the app, because it does seem like there is quite a few domains. So, who will that from?
Sorry, you cut off a little bit. Could you repeat the question?
Sorry. So I was just wondering how the app will be integrated into the patient's care, and whose role will it be to instruct them on how to use the app?
Yeah, so as we mentioned before, our app complements phase 3 of the current model of survivorship care. So we hope that primary care physicians or their doctors would recommend the app to the cancer survivors and encourage them to download the app to track their nutrition intake, etc. As for how they will learn to use the app, we would have a tutorial upon first launch of the app that would instruct them on the different sections and give them a clear overview, because we do understand that there might be difficulties with digital literacy. So we hope by having these small things would help the users feel more comfortable using the app.
And just another question. So I guess in terms of the fitness side of things, so we know there's never a one-size-fits-all approach for cancer survivors. So how will that section be tailored to the individual using it?
Oh yeah, I can take that one. So as we mentioned before, the fitness section is sort of just like a hub, just where you'll be able to access more resources onwards. But what we provide are simple exercises of varying fitness levels. So ranging from intensities from low to high, depending on the person. So the user will be able to choose what kind of exercises they would like to do and how many of them. And then we will provide further resources depending on their fitness types as well.
Yep, and just to add on to that, when you first sign up on Survivor Diner, there is like a filter where you can kind of log in, what cancer comorbidities that you've had, and then the app will kind of just be tailored towards that.
Yeah. Okay. Thanks.
Can I ask a question about feasibility and acceptability? So thinking about the demographic of survivors, and I guess that lots of people have intentions of modifying their diet, exercising more. Can you comment on what your initial thoughts are about uptake and people regularly using Survivor Diner? So I guess it's about initial uptake and then maintenance.
Yep, so I think with any type of nutritional plan or diet plan, there will always be problems with compliance as time goes on. So we hope that by having the community aspect, first of all, that when you form connections with other people in the community, you can increase your accountability in a sense by having other people check in on you and encouraging one another to follow the diet plan. And sorry, was there another part to your question?
I guess it was about uptake, so people signing up and then people maintaining participation.
Yeah, so for the initial uptake, I think if the app can be endorsed by their doctors, then it would, give the patients a sense of trustworthiness towards the app, which would help them with the uptake of the app at the beginning. Sorry, did anyone want to add on?
Yeah, like we mentioned before, things like seeking endorsement from the Clinical Oncology Society of Australia, just kind of using that to help to educate health professionals to help recommend it to their patients. So that would help with the initial uptake. And in terms of like things like compliance, and user engagement, we'll be conducting things like, just doing market research throughout the app to make sure that we're constantly, taking in feedback and implementing changes that can make user use easy. And also, like Vanessa said, the community aspect kind of makes individuals accountable and also fosters a sense of community so that people can actively participate and fully utilize like the app's features, and also having in-app app notifications to, motivate users to check in.
Nick, did you have anything?
I suppose my query is really around the novel aspects of this proposal, because it in some ways it combines, or it appears to me to combine things that are already available to the general public. So mindfulness apps and online fitness apps and various dial up and have your meals prepared for you and sent to you. So convince me that your app isn't just mimicking those things and is offering something to survivors that is actually novel and new.
Yeah, so like our app is novel because we have like all these features together, but it's specifically tailored for cancer survivors. So for example, like the fitness section, like for like regular fitness apps like that we have used, for example, like 5 minutes daily exercises, like those ones, they're not like specifically tailored for cancer patients because they're not as like fitness, like in terms of like their state of health, like the ability for them to do the activities, it's quite limiting due to their cancer, right? So like we have tailored like the fitness activities to varying levels, so to suit like their capabilities and how they can do the activities. Yeah. And also, yeah.
Oh, sorry.
Okay.
We also did research while we were creating this model. We looked at other current apps on the market, and we realized that a lot of them we did not find one that actually combined all of our features. And the one that we did find that was most similar was only tailored towards breast cancer patients. Meanwhile, our app is tailored towards all cancer patients, and any type of cancer can be tailored because of the way that you sign up. Through your user profile, you'll enter your cancer type, your comorbidities, your treatments. I think the reason why our app is so novel is because it can specify, for example, the nutrition aspect so well to cater to each individual. And I don't think I've seen that on the current app market right now. Not that we've seen. Yeah.
Thank you.
Yeah, sorry, I'd just like to tag on the end of that. So a well-known meal kit delivery service, for example, is HelloFresh, which we looked into as an example of a successful meal kit delivery. And we found that there is a very limited range of meal selections available, and you can't tailor anything such as sodium intake, potassium intake. And all these electrolytes are important to maintaining health, especially for those cancer survivors with comorbidities, which is pretty common. And I think with our app, having all the different components in one makes it more accessible, because people are more likely to download one app that has everything in it than 4 separate apps, which requires more dedicated time. So I think our app is, the sum of everything is greater than each individual parts.
Okay.
Yeah.
So due to time constraints, I think we'll end the Q&A session here. So thank you very much to Cave, and now we'll welcome our next team. So if sharing is caring is ready. You guys may share the screen.
Right, I think team sharing is caring should be back by now. Please feel free to just start screen sharing when you're ready.
Is anyone from Sharing is Caring here?
Sorry about the delay, guys. They're here for real now. So team sharing is caring. Please feel free to start when you're ready.
Can everyone see my screen?
Yep, you're good.
Yep.
Okay. Esteemed panelists, family, friends, audience members. I'm Stephanie, and I'm joined by the lovely Caroline, Christian, and Dana, and we are the team Sharing is Caring. Cancer survivors have unique health needs persisting beyond their active treatment phase. These issues fall under the patient experience, the medical professional care team, and the healthcare system domains. From patients feeling underprepared and overwhelmed, to experiencing underrecognized and hence undertreated symptoms, to patients and even members of their care team sometimes lacking important information. Finally, there have historically been limited key performance indicators and an ineffective use of nursing and allied health reviews.
Our proposal is best suited to patients who have completed their active cancer treatment within the last 5 years and is composed of 3 parts. The first part involves creating a 1-year transitional program, which involves an initial assessment, 6 and 12-month appointments that will occur in the GP's room with the oncologist joining via telehealth. This will provide the patient with a treatment summary and a future plan, as well as ensure coordination of care at hallmark points in the patient's survivorship journey. At the 3 and 9-month mark, there will be additional extended length GP appointments where the GP can evaluate the patient's physical, mental, and social well-being and continue patient education. The second part will involve the GPs being provided with education on cancer survivorship care as part of their registrar training and as GP consultant continuing professional development, which Christian will elaborate on later. Finally, we will be creating an oncological needs assessment tool for patients to use to identify their needs and goals and to direct allied health input into their care.
Our proposed model of care will address the unique health challenges previously described by Steph. The 1-year transitional program offers a guided handover of care from the oncologist to the GP, with recommended GP review window periods. Our educational curriculum engage GPs on existing unaddressed problems facing cancer survivors. The E-modules fill knowledge gaps surrounding under-recognized or undertreated symptoms, the importance of healthy lifestyle education, evidence-based complementary alternative medicine options, the psychological needs of cancer survivors, and on how to best coordinate cancer survivorship care between the multidisciplinary team.
Here we've summarised the impact of our model of care from the perspectives of different people involved. For the patient, the program is designed to enable them to develop confidence and competence in advocating for their needs, contributing to early psychological and emotional support where needed. Shifting to a GP-led model will also allow patients to receive culturally appropriate care closer to home, especially important for rural and regional Australians. For their family and carers, this will reduce the time and costs of travelling to specialist appointments. Our model will facilitate a transitioned handover from specialists, and allied health workers, psychologists and nurses may take on a greater role in the team, including delivering education about lifestyle and complementary and alternative strategies to optimise one's quality of life. GPs' participation in the online training will give them greater confidence in navigating ongoing chronic disease management for these patients and in identifying their health needs and coordinating the holistic care team. To assess our progress in meeting these expected goals, we can review repeated needs assessment questionnaires to track whether patients' symptoms and needs are being addressed appropriately and in a timely manner. Patients have the option of completing a survey after 12 months of the transitional program to give feedback about the quality of care delivered through our model and suggestions for improvement. Additionally, we'll be able to assess GPs' participation and completion rates of the online learning modules and receive their feedback regarding its content and delivery. We can see whether the learned material is translated into practice by the completion of repeated needs assessments and the billing of MBS items 721 and 723. In the longer term, we can look at spending per patient and morbidity and mortality data to see the effects of our model of care at preventing chronic health issues in this population.
Our model addresses multiple stakeholders. Cancer survivors are our target population. General practitioners and specialist oncologists make up the medical bodies involved in cancer survivorship and our transitional care program, which also involves allied health input. Moreover, we involve the Australian economy and government for funding and research institutions so we can integrate evidence-based research findings into our model of care. We have incredible existing resources that we hope to integrate into our model, such as My Care Plan, the Needs Assessment for Cancer Survivor Toolkit produced by the Australian Cancer Survivorship Centre and Peter MacCallum Cancer Centre, as well as Department of Health programs such as the Chronic Disease Management Plan and Team Care Arrangement. Cancer Australia provides vital access to survivorship support services and patient networks, including representatives from certain population groups identified as requiring further support. We also call upon GP and oncology college input towards our e-module curriculum and transitional program design, and for access to their online systems to integrate our modules. Our proposed timeline involves a single-year development phase for expert input into the proposed model of care design and recruitment of our pilot GP sites, followed by a 2-year implementation phase during which pilot sites initiate the transition program and facilitate ongoing evaluation. Throughout the implementation phase, outcome measure reports will assist us in refining the program and in funding re-evaluation and resource reallocation for ongoing years.
Our program has a number of risks. Patients may struggle with taking ownership of their care and may face difficulties in identifying their treatment needs during the initial assessment phase. To counter this, we plan to upskill patients with the health literacy and knowledge to empower them to manage their care independently, and we will repeat our needs assessment to ensure that patient needs are not missed. Having a GP-run program does pose the risk that issues beyond the scope of the GP to manage may arise, and raises the possibility of conflicts in advice between GP and specialist. We propose rapid referral pathways to the specialist for issues beyond the GP's scope of practice, and for both GP and specialists to collaborate to create a centralised shared care plan at the initial assessment. Our program is limited by the willingness of GPs and participants to participate in this program. And to enable GPs to participate in cancer education, we are delivering our program online 24/7 and free to access on the RACGP and ACRIM learning modules to increase accessibility to GPs working both after hours or in rural and remote areas. Patients will be given the option of whether or not they wish to participate in the program, and if they do, they will be educated about the principles of the program to encourage their ongoing participation in follow-up care. We are limited by our budget and hence are only creating a pilot program for a limited number of survivors. If effective, we will be petitioning for ongoing governmental funding for expansion. Though Medicare coverage of allied health appointments are limited, by using the needs assessment tool, we plan on ensuring these appointments are put to the best use for the patient.
Our budget has been divided into the three components that make up our proposal. We've estimated the creation of the development of the transition year program oncological needs assessment tool to cost approximately $6,800 each, and the GP education program to cost approximately $44,000. This includes the creation and analysis of surveys for our major stakeholders, from cancer survivor patients, general practitioners, oncologists, etc., as well as for the actual design of the programs, allowing for several drafts with input and reviews by experts in the field. The first year post-active cancer treatment will cost approximately $840 per patient, accounting for the Medicare benefits schedule payments for the regular GP and oncologist telehealth appointments, as well as the utilization of our standardized oncological needs assessment tool twice. We've estimated the maintenance costs of the GP education program to be approximately $2,000 per year for analysis and evaluation, to help the education program stay up to date and relevant with the ever-increasing field of medical knowledge and responsive to any new needs and concerns identified by patients receiving this new standard of care. We've then worked backwards in order to utilize our budget to the maximum potential. Under our proposed model of care, we'll be able to provide increased GP education to our general practitioners in the RAC GP and ACRIM colleges, and be able to pilot this transition year program for 5,900 unique patients, putting our total cost at just under $5 million. Traditional models of follow-up care in the survivorship phase involve patients returning to the oncologist team for 3 to 5 years after completion of active cancer treatment. This is predicted to be unsustainable in the context of the increasing trend in cancer survivorship, with our aging population of Australia, advances in screening, early diagnoses, and novel and improved cancer therapies. Primary care-based models of care have been shown to be non-inferior to specialist-led care, with the additional advantages of being able to cope with this increasing need, stabilization of healthcare costs, and further accommodating for patient preferences of care delivered close to home. We aim to improve patients' quality of life and satisfaction, and overall improve their physical, mental, and social well-being. Our proposal aims to reduce healthcare costs via multiple ways. Firstly, safely migrating patients from specialist care to the primary care setting. Secondly, through the prevention or early identification of common issues that can arise in the post-treatment setting. Thirdly, through the promotion of patient involvement and engagement, which has shown to result in improved self-reported health, fewer hospitalizations, and reduced health costs. Finally, through utilization of allied health and nursing to help patients regain function and ability to comfortably reintegrate into society. Thanks for listening to our presentation, and these are reference lists. We're happy to take any questions.
Thank you, sharing is caring, and we will now pass over to the judges for question time.
I'll ask a quick question if I can. 5,900 patients seems like a lot for a pilot study. Is there thought about perhaps potentially looking at the data earlier on rather than recruiting so many people to see whether or not the program is working as intended? I'm just wondering whether you might have thoughts about perhaps after 100 or 200, that's still a very small percentage of the total number.
I think that's, sorry, I'm Stephanie. I think that's definitely a really good point. The reason why we came up with 5,900 was because we wanted to use the budget that was stipulated within the case files, which was $5 million used over 3 years. I think that's definitely a good point that we could think about. But from our point of view, we were just trying to sort of maximize our yield from what we were given, I guess.
And if I might add to that, in terms of ongoing outcome measures, we will be trying to tweak the program in the 2nd and 3rd year of development. As you can, if we can flip back to that slide, Steph. And what we hope to do is to listen to the feedback from the patients, from the oncologists and from the GPs to see if there's anything we can do to improve our program as we go along.
So I might ask another question, if that's right. Well, congratulations, first of all. The GP education program, I guess when you were preparing this, did you come across other online GP education programs that already exist? And can you convince me that we need another GP education program? or is it more actually, are there other more important components that really are required to implement this beyond education?
Well, when we were researching for this, we certainly did come across a lot of other GP online modules, such as the dermatology and alcohol and other drugs modules. And considering that cancer survivorship is becoming much more prevalent in Australia, we thought that many GPs would be personally interested and invested in getting some further knowledge in this area to be able to better treat patients in their care who have a past history of cancer. As for other components that could be more important or vital to accompany the education that we provide GPs, we've talked about the potential benefits of having those three-way telehealth conversations between GP, oncologist and patients. So the patient, just to clarify, will be in the GP's room and the oncologist would be present on the screen. And we think that would be a really helpful supplement to those online modules. By seeing the interaction between oncologist and patient, the GP may be able to consolidate their learning and further deepen their knowledge in that area.
And if I may add on to that, we've shown with research that, or research that we've done, that there has been areas of cancer survivorship specifically that patients have reported have been lacking in their GP consultations. For examples, including discussions of primary cancer screening, discussions of psychological changes, and discussions of even just regular health checks. So our hope is that through the GP education program is that we tailor our curriculum specifically towards tackling these identified problems that are unique to the health challenges affecting cancer survivors. And hopefully in that sense, it would be more specific for these issues that we're addressing.
Could I ask a question? And I'm wondering how you deal with survivors who don't actually have a GP, because a lot of survivors don't.
I think as part of this program, we'd probably encourage for survivors to have access with the GP. So by establishing connections between the oncologist and GPs, we're hoping that there can either be some kind of a referral from the oncologist onwards to a GP or recommendations made, because we understand that GPs are very well placed to be looking after a lot of the issues that survivors may be facing. And sometimes it takes that joint connection between the three parties before survivors may be willing to take on a new GP. And often because we know that in that first year after completing active cancer treatment, survivors do feel maybe a bit abandoned by their oncologist. What we hope is that by having that initial assessment where the GP, the oncologist and the patient are all together, we can encourage there to be a bit of a facilitated communication between the three parties and hopefully encourage patients to take on a GP, even if they didn't already have one.
Additionally to that, just if I might add, as part of our development into the program, we've also involved input from other networks such as Cancer Australia, and our hope is that they would provide further access to, or at least support into certain programs and representatives that will better help us penetrate these population groups who we aren't originally able to target through a generic advertisement to GP clinics.
Mm-hmm.
I see that you're going to try and persuade the government to create a new MBS item. What challenges do you think you're going to face, and how critical is that to your model?
So I think the point of having the oncological needs assessment tool is really to target the specific things that cancer survivors may face. For example, allied health workers such as lymphedema care nurse or stoma care nurse. So these things are part of allied health and would be a really important part of the patient's journey. And that's why we've decided to create this new MBS model that's sort of based off the GP management plan for chronic diseases, in that it helps like patients receive a certain amount of allied health referrals that they can use. It's subsidized by the government. So I would say that I think that it's a good question, but I think that it's part of the post-cancer treatment care, I guess. Yeah, and just helps to direct which allied health referrals they should be getting.
And I agree that it's a pretty key part of our model of care, but I don't foresee that it would be impossible to do. Other models of care, such as for osteoarthritis, have started out with a pilot program that have involved the creation of, say, a chronic disease plan, and those have gone through to being used in practice today. So we do foresee that osteoarthritis is a chronic disease, cancer is a chronic disease, and there's nothing to say that the burden of cancer is any less than that. So we'd hope that that is taken up well by the government.
Yeah, we have 1 minute until the end of the question time. Judges, do you have any last question to ask the team?
Not from me, but there's one in the chat.
Yep, so we'll just grab the question from the audience. The question is, would it be feasible to have this program integrated instead into an MD curriculum instead?
I believe that that might be referring to the GP education modules, having them integrated into an MD curriculum. I think there's plenty of modules online that are available to a really wide audience, so medical students as well as junior doctors and even consultant GPs. So the way that we've targeted it on RACGP and ACRM sites means that it's really available to anybody with memberships to those. And hopefully in the future it feeds itself down the line and finds itself in the curriculum for medical students. A lot of the issues that they will be covering in it will be more clinically focused and tailored to GPs and their level of practice, particularly as Christian said, about things like ongoing screening, shared decision making for younger cancer survivors, and treating the late stage effects of aggressive cancer treatment. So if we can find a way to simplify it and make it relevant at the MD level, I'm sure that it could be modified that way. As is, it's a bit more GP focused.
And so speaking from a more personal point of view, all four of us are currently lucky to be studying medicine. We're in the final year of medicine, and I think that we do get lots of teaching about cultural safety, cultural awareness, and things like how lifestyle impacts physical health, as well as like psychological things that we should be thinking about. And like we all know this, but I think just speaking from when we're in placements, I think it's quite easy to forget about the things that you don't see, obviously. Like you can see a patient who's sick, who has a wound, and then it's easy to focus on treating that and addressing that. And it's a bit harder for us to reminded to say, you know, how are you going? Like, how's your family? How are your social supports and your carers and things like that? And that's really what we're intending to try and remind general practitioners, even though like the day-to-day practice is busy and they're focusing on treating patients, just reminding them of the things that sort of are just underneath the surface, and reminding them of how, like, what a difference and impact they can make in people's lives.
And I think
sorry, we'll have to stop there. We will have a quick break of 2 minutes, and we'll come back at 6:47 to resume with the next two teams.
Might give it a few seconds just for everyone to come back, and then we'll start on the next team shortly.
We're now being ready to start the second half of the night. Can I ask that all judges are ready?
Yes, I'm ready.
That's okay. Maybe we can give a bit more time. We're all good. Okay, awesome.
Wonderful.
I'll pass it on to you, Oscar.
So we'll welcome our next team, and so transfer of trust, all yours.
Right, I'll just share my screen. Can we all see that? Great. Hello to our wonderful audience, panel members and colleagues. We are the Transfer of Trust team, and we thank you for giving us the opportunity tonight to walk you through our survivorship program. My name is Miller, and I'd love to introduce my teammates, Nick, Beck and Ash. I'll be giving you a general program overview, and then Nick will explain the important people to our program, followed by Beck, who'll explain the inner workings of the model, and Ash will then discuss the program's budget, strengths and weaknesses. The development of this program was a collaborative team effort, and we draw upon our individual strengths and experiences, some of which involve stories of cancer survivors that are close to home. But first of all, Ash, why did we name it the Transfer of Trust?
Well, Miller, it comes from the key step in our program, which is the transition of a patient's care from the oncologist over to their GP for the survivorship phase. And this was built to improve on the current model of care, which relies too heavily on tertiary centres.
That makes sense. So, running you through the program roadmap, we start with a survivor who is undergoing their cancer treatment. They then have this transfer of trust meeting with their oncologist and GP. At this meeting, the Transfer of Trust app is downloaded and the tracking phase is commenced, where the survivor is encouraged to use the app for regular check-ins. These questions include mental, social, financial and physical wellbeing aspects of survivorship, integrating a more holistic model than what's currently used. The app itself is built as an extension on the Peter Mac app called Second Ears. There are personalised resources and an easy to follow interface. As you can see, pictograms are used for physical symptoms, and the last screenshot here shows some of the targeted resources that could be linked to the user. Now on to Nick to explain the key people to our program.
Thank you, Miller. We believe that the rich and diverse views of these stakeholders are essential for designing a program that is successful, sustainable, and provides the greatest benefit to survivors. Therefore, we plan to engage all stakeholders early and often to ensure the transfer of trust can seamlessly integrate into the existing landscape of survivor care. Our program doesn't stream survivors by cancer type. Instead, understanding that whilst no one survivor's experience is alike, the survivorship phase is intrinsically human. We therefore open the transfer of trust model to any adult survivor of cancer in Victoria. The recruitment process will utilise that used by second years through PDMAC to ensure seamless integration into clinical practice. Additionally, this program is still of benefit to those of high medical risk who will have ongoing, close input from their oncologist, as the Transfer of Trust program has the flexibility to ensure holistic care for all survivors. So let's take a closer look at the transfer phase. Since diagnosis, a survivor's oncologist has been their lead doctor in their care. To get this care, they might have travelled far from home, incurring costs of travel, parking, and specialist fees. However, a survivor's oncologist is a clinician whom they have built a strong clinical relationship with. They might feel that this is the only doctor who understands their needs. We know that GPs can provide many aspects of survivorship care. However, evidence tells us that for survivors, transitioning from an oncologist to a GP is a daunting process. Therefore, our model formalises this process through a transfer of trust handover meeting between the survivor, oncologist, and their GP, helping the survivor to build trust within their general practitioner. This meeting utilises existing Medicare benefits schedule item numbers to incentivise GP engagement and financially support the program. For our program's success, we need doctors and survivors to have a good understanding of how this program works and why it is better than the current model. Tailored information packs will be designed to inform survivors, oncologists, and GPs. Importantly, we recognise that GPs may desire further training in survivorship care, so their pack includes information about professional development programs, such as the EVQ survivorship modules and the PDMAC GP placement program. We hope that by doing this, GPs can feel equipped to make survivorship an integral part of their practice.
Thanks, Nick. Now we enter the tracking phase, which has a dual monitoring system coordinated by the app. Firstly, there are optional daily or weekly wellbeing check-ins. Secondly, there are validated surveys that occur at the 1 month, 3 month, 6 month, and ongoing 6 monthly review points. Used together, the GP is able to make informed recommendations targeted to the specific needs of a survivor. Survivors will be encouraged wherever possible to self-manage through resources taken from the Cancer Council directory via the app. Identified red flag changes will encourage survivors to initiate their own GP reviews wherever needed. As an example, a survivor could complete a weekly check-in that identifies sexual dysfunction as a recent troublesome symptom. This would prompt a reputable resource about sexual health and cancer, which includes a list of professionals to talk to, as well as ways to broach the subject with a partner. This removes Dr. Google, and evidence suggests that this can improve survivor satisfaction and outcomes through patient empowerment. More formally, at the 1 month, 3 month, 6 month, and ongoing 6 monthly review points, a more extensive screening process can take place with the GP. To do this, the survivor would complete a series of validated surveys from the Functional Assessment of Chronic Illnesses instruments, and the overall trends would help dictate the potential interventions that would be required. Uniquely, our model screens for the social, mental, financial, and functional impacts of cancer long-term. This allows our system to integrate symptoms outside of physical health into every review of a cancer survivor. As a second example, a survivor could complete a 12-month cost survey and be placed in a high-risk category for financial stress. At the GP review, this would be flagged to the doctor, who could be prompted to initiate a social work referral or a mental health care plan, or simply this could act as a springboard for discussion. Clinical judgment is still at the heart of our model. However, these periodic reviews will ensure that commonly missed domains of cancer survivorship continue in the long-term discussion.
To quickly take you through our budget, we estimate that the project will cost $3,525,000 over 3 years. And this includes costs for stakeholder consultation, recruitment of participants, incentives, staffing, app development, and IT costs. The GP side of our program is partially funded through existing Medicare items for cancer case conferences and chronic disease consultations, and GPs may choose to add a gap fee as per their normal practice. Our budget figures were calculated using University of Melbourne research resources, including their salary calculator and past grant applications published in the Research Gateway. Once the 3-year funding period is over, we anticipate that our project would be administered by the Australian Cancer Survivorship Centre and funded by PDMAC and Cancer Australia. So using a SWOT framework, we've identified a number of challenges and enablers to the success of the transfer of trust. Our model incorporates existing systems and resources into an easy-to-use, personalised survivorship experience. One strength is that it will decrease the burden on tertiary care providers. Our program is evidence-based and it has been modelled off the optimal care pathways, with another strength being that our model can be applied to all cancers and accessed by regional and rural survivors, where the GP's role could be replaced by a nurse practitioner. There are some limitations to our model, however. The program will need to be adapted for particular groups, including Aboriginal and Torres Strait Islander peoples and people who are vision impaired. We'll consult stakeholders in this process to ensure appropriate implementation for these groups. Additionally, because this is a novel method of survivorship care, it hasn't yet been validated through research. A major opportunity for the transfer of trust is Peter Mac's transition to a new electronic medical record system, which enables app integrations, remote data access, and telehealth consults. One of the threats to the success of our program is that we require buy-in from clinicians and patients, and this will require a shift in expectations, which will develop as the benefits of the program are illuminated. Other threats include patients without a regular GP or who live in places where there is no primary care. We hope to overcome this with the changing landscape of telehealth opportunities in the post-COVID era. We believe that our model can change survivorship care for the better. We'll measure the acceptability and success of our project through qualitative and quantitative analysis using surveys of stakeholders who participate in the first implementation stage and through health economic analyses to ensure a favourable cost-benefit ratio compared to standard care. Ultimately, we'd like to confirm that not only does our model better address survivors' needs, but that it works well for oncologists and GPs too, and it costs less than tertiary care.
Thanks, Ash. Wrapping up our presentation, we anticipate this as the project timeline. A core program team is to be established with early contact with stakeholders initiated. The app would be developed by Wave Digital, and following a preliminary rollout at 1 year, we would be assessing the program's impact as discussed by Ash. At the 2.5-year mark, it would be rolled out to all participating tertiary cancer centres with further assessment of user engagement, analysis and impact. And that brings us to a close. Thank you for listening to the Transfer of Trust, and I would like to open out to questions from our panel and audience.
Congratulations, well done. Can you tell us a bit about the impact assessment and how you know whether this is actually a good thing? And also within that, maybe you could comment, there was a remark about making sure it works well for different health professional stakeholders. How will you assess that?
Thanks for your question, Michael. So the first aspect of, I guess your question is about how we're going to measure this as an impact and the ongoing measurements that we're using. We'll be using they're called PROMs, the patient reported outcome measures, and that's part of the analysis process that was mentioned in that timeline. I think that something that is important that you mentioned was the initiation of different stakeholders like nurse practitioners and allied health staff being involved in the app's development, because while it is a very flexible model, we do need to be able to tailor that for different users depending on the workflow of that practice. So that's something that we would be addressing there. Did anyone else from the team want to add anything in that regard? No, happy with that. Did that answer your question, Michael, or did you want us to further elaborate?
I guess it was about, you said, making sure that it works well for different professional groups. How do you define works well for them?
I think in terms of working well, it is really an ongoing process and engagement and discussion with different stakeholders. This isn't going to happen with a one-off meeting. And that's why I think that the development of any program, you need really early stakeholder involvement and ongoing review and discussion. So, you know, idealistically in a non-COVID era, these would be happening together in the same room. But, you know, over Zoom would do, and ensuring that the prompts are assessed as well as whether people are satisfied with the outcomes of the app, whether there's changes with survivorship baselines, whether they feel engaged and supported, and as well whether GPs feel as though this is adding to their practice, streamlining the process of survivorship care, rather than being an added burden, which is something that we don't want.
Can I go next? Sorry, Meg, did you want to go? Okay, look, very nicely presented. You're clearly beginning this work with Peter Mac, and how would you think about scaling this up beyond a single large cancer centre, and what were the challenges that you face around that scale up?
Yeah, so I guess the whole idea is that if we start with Peter Mac, obviously they're one of the biggest catchments of cancer care across, like, at least in Victoria. So they had about 37,000 cancer patients come through their doors last year. If we start here and if we can show that it works for Peter Mac, that'll give us a good case approaching other centres that have cancer care, whether that's interstate or even across Victoria that aren't managed through Peter Mac. And some of the challenges to that would be figuring out how our app and the interface that we've created using the Peter Mac EMR can be implemented in other places. So hopefully we'd be able to work with each individual cancer centre to design a workflow that works well for everyone and that can integrate with how their standard practice is.
That my question actually followed on from that, because my sense was that if you're using the Parkville precinct EMR, I wasn't sure how you would then roll that out to other centres if your program is designed around that. If other centres don't have electronic medical records, how are you going to work with them?
I think you raise a really valid point, Meg. And while we are moving towards electronic medical records across the state, this is something that we would definitely face. I think part of having an app is that it is in the survivors' hands, and they control they can see their trends, they can see the outcomes of their surveys. And we anticipate that a web-based version would be accessible by their GP as well. So while it is connected intrinsically to the EMR of Peter Mac, it is able to be used as a separate entity and controlled by that survivor, which, you know, we know feeds into that self-empowerment and control over one's chronic illness.
So I have a follow-up to that, I suppose, and it's something that I hadn't thought about earlier, but I think it relates directly to your program, and that is that GPs don't use sophisticated communication. They don't use it between them and the hospitals. They don't use it between them and their patients. They work via fax. They don't even email. So how does this fit into current GP practice?
Yeah, that's a really good point, Meg. I mean, we've all had experiences of having to ask GPs to fax over their medical records, and hospitals work the same way too in some places. I guess part of at least the COVID landscape is that there's been a huge shift, and most GP practices do use some sort of electronic patient tracking system. They might not put all their notes in there depending on the individual GP or practice's preferences, but there is some sort of system. So in that sense, having them have remote access to Peter Mac's EMR probably is adding yet another thing to the GP to have to access, in addition to pathology and all those sort of online portals. But if they don't want to do that necessarily, going back to Milla's point, the app is in the survivor's hands. And we do have options that if the patient doesn't want to use an app, or the GP is really against it and prefers paper records, we could administer those surveys over paper. The key part is having the oncologist and the GP and the survivor together, whether that's over a video conference, phone, or in the same room, hopefully, to facilitate that transfer. And then how the GP and the survivor navigate their ongoing management from there is going to be a negotiation on what works for them.
We have 2 minutes left in the question session. Judges, do you have any last questions for this team?
I hope there's one that's popped up, I see in the chat.
I'll just read out that one from the audience. So the question is, how do you ensure that the data being reported by the patients is accurate? For example, if I'm a child cancer survivor, I might report my symptoms inaccurately because I might be scared to go back to the hospital. I was wondering how this could be countered. Thanks so much.
Sorry. Great, thank you so much for your question. Firstly, I think that it's really important first to say that this would be for adult patients. And secondly, I think it's important to acknowledge the evidence base out there at the moment for self-management and patient empowerment has some really great success rates seen at the moment. And that this is a natural concern, but what we're seeing in the trends of evidence is that people really do want to engage and be part of their own care, and that even taking it to an app platform will hopefully even help people further to feel like they can express their issues or identify any issues that they want to help with. Might pass it to Mila now.
Yeah, I just wanted to add there that this doesn't replace that, as we were discussing in the talk, that clinical focus and interaction between a GP or their health professional and the survivor. So any sort of missed, incorrectly reported information or trends would be mitigated by a GP consult and discussed in person. So I think that would be a risk mitigation strategy we'd use.
Thank you, Chancellor of Trust. This concludes our time for question and answer, and we will move on to our final team, Kanke.
Thank you.
Kanke, are you ready to share a screen?
Yeah. Do we start sharing now?
Yep.
Okay.
All yours.
Okay, good evening all. So for our solution, we have focused on adolescents and young adults living beyond cancer. We've chosen to target a specific demographic because we believe that different groups have unique needs which warrant unique solutions. For instance, AYAs currently have limited models for them. However, early intervention is crucial for their long-term health. Our two-part model is centered around the 3 pillars of survivorship care: the role of the individual, the healthcare system, and the community.
Our app, CanCare, works off the principle that self-management by AYAs is often daunting and hard to stick to. There are many unanswered questions in the minds of these individuals, such as where to find information, what kind of support is available, and how to access these support systems. As such, CanCare is multifunctional in that it helps AYAs track their data, provides information about common concerns and where to find help, and overall supports AYAs in their journey, directing them towards support systems where necessary. This app will guide AYAs using notifications and prompts, as well as motivating them utilizing the My Garden feature. Okay. Exercise. The official survivorship exercise target is difficult to meet as AYAs have low motivation and morale, as well as experience fatigue and pain, although exercise is clearly an important component of recovery and a healthy lifestyle. The app involves a log of daily exercise, including the time spent and type, as well as daily reminders to exercise and exercise streaks to increase motivation. The app's algorithm finds trends. For example, if a user's mood is improved on days where they exercise more, these findings will be presented to the user as encouragement. The app also utilizes GPS navigation to display virtual checkpoints that, when reached, unlock rewards like unique animals to house in their virtual gardens.
Our app also addresses the fact that many AYAs have nuanced psychological needs which are inadequately screened for. So in our model, AYAs are prompted daily to track their mood. Trends are then created, and most importantly, logging a consistently low mood for more than 2 weeks will prompt a pop-up, which refers them to resources as well as support services such as counselling or seeing a GP for a psychologist referral. There will also be mindfulness exercises in this app.
Poor sleep, chronic pain, and fatigue can all have negative impacts on mood, mental health, and confidence in social settings. So the CanCare app will provide users with a sleep log where they are able to self-manage their sleeping habits by recording the quality of sleep and daytime activities undertaken, which are then analysed by the app to provide tailored advice for the individual. Our proposed pain and symptom diary encourages young cancer patients to rate their pain and complete a checklist of common symptoms, which have been built into the app. Based on data collected concerning the continuity and localization of pain, the app would provide alerts when high-risk symptoms are being experienced and immediately prompt a visit to the appropriate health professional.
The question and answer domain of our app contains answers to a multitude of questions specifically relevant to AYAs, including verified medical health information, financial management tips, and social reunification. We can imagine that it would be otherwise incredibly stressful to not know where to find reliable information, other than by endlessly consulting your GP out of your own pocket. This information bank will allow people to immediately find answers while potentially removing the embarrassment of asking simple yet significant questions. Beyond the app, our model also helps people to connect and learn. Our research revealed that AYAs can become socially, educationally, financially, and occupationally disadvantaged by the consequences of cancer. Therefore, we felt that it is crucial to create a bottom-up model of support whereby AYAs are equipped with useful and important skills. Our budget funds a series of free fortnightly workshops to AYAs featuring expert speakers with a website supporting email reminders for upcoming events.
A very high degree of health literacy is required in AYAs. Although this knowledge is not commonly taught at schools, it is often assumed knowledge in people living beyond cancer. Our model involves workshops and lectures delivered by healthcare professionals and experts introducing AYAs to common terms they may encounter, various medical procedures, and which healthcare professionals to contact at what times. Through these, AYAs will glean a better understanding of medical terminology, allowing them to better understand their options and communicate effectively with their doctors so that they can make informed decisions together with them.
Additionally, many AYAs are nearing the age of financial independence and may therefore experience hardships. Our financial skills workshops offers the necessary budgetary skills to ensure they can confidently manage their own money. Since young cancer patients have also missed a great proportion of their education due to treatment, we have proposed study skills workshops to teach students generic skills to aid their return to study. Some will face challenges returning to current or finding new employment, thus our workplace skills sessions will strengthen their employability and assist with job seeking. These workshops provide vital skills that will not only assist with reintegration into society, but also have a positive effect on mental health by reducing financial and educational anxieties. Also, far too often, young cancer patients feel a sense of loneliness due to difficulties reconnecting with old friends or forming new relationships. To combat this, we have proposed interest groups and peer mentoring networks, which may be held following the upskilling workshops. Our interest groups foster the development of new friendships and provide inspiration for new passions and interests. Peer mentoring offers young individuals guidance as they may be experiencing social anxiety and a lack of control over their own lives. These are led by an older volunteer living beyond their cancer to ensure our young mentees feel comfortable discussing their health and hardships with people they can easily relate to. They may even be inspired to return to volunteer in the future, thus ensuring the sustainability of our community engagement proposals.
Our budget focuses most heavily on developing a functional and secure mobile application for Apple, Android, and Windows mobile phones. We are also strongly investing in the organization, presentation, and publishing of our upskilling workshops so that they are accessible to AYAs. To ensure that our strategy is successful, we have directed funds towards measuring the usefulness of our model. And finally, we invested in establishing partnerships with medical practitioners and other forms of promotion to guide AYAs to our services as soon as possible.
Implementation. Overall, we aim to launch the upskilling workshops at the start of 2022, assuming the 3-year program begins next year, which is 2021. This will be followed shortly by the launch of the app in June of 2022. Before the launch dates, the attention will be mainly concentrated on the preparation and recruitment of resources for the launches, as well as promotion. After the app and workshops are launched, the focus will be mainly on collecting feedback and making improvements, thereby making arrangements for the future and conducting studies to assess the impacts of the efforts.
To prevent the risk of information becoming compromised, we have heavily budgeted for app privacy and data security. Additionally, we consider that our upskilling workshops are less accessible and socially engaging to rural AYAs. To compensate for this, our workshops will be recorded and uploaded to our website. Moreover, we realize the risk in funding an app that AYAs may not know exist. Therefore, we have allocated a significant proportion of our budget toward partnering and communicating strategies for implementation and support for health professionals, including the upskilling of GPs.
Our app has 3 main intended impacts. So firstly, we're promoting long-term self-management of what is increasingly seen as a chronic condition, hence helping primary and secondary prevention of complications through both our symptom tracker and a healthy lifestyle. Secondly, we're also screening and intervening for the invisible impacts that are given less attention in current models, things like financial health, psychological needs, and physical symptoms like sleep. Thirdly, this will also help distribute out care by directing AYAs to different components of the healthcare system. For example, a low-risk symptom will direct you to a GP in our app, while mental health issues would take you to a psychologist. To measure our impact, we will have patient experience surveys, which will ask participants to subjectively rate their experiences. We will also establish small focus groups with key stakeholders to look more deeply at the issues. We have also allocated budget to research studies to objectively look at the long-term outcomes over, say, a 5 to 10-year period. So things like employment rates, education completion, utilisation of primary care versus specialist care, and the incidence of side effects. So to summarise, we have 2 parts to our model: the app, which tracks physical and mental aspects, and our workshops, which will be addressing the financial and social aspects of cancer survivorship. Thank you for consideration of our proposal.
Thank you, Kenke. Judges, would you like to ask Team Kenke any questions?
Joe, I think you might be muted.
I'll start, I guess, because I can't see the other judges at the moment. I'm not sure where they all are. One of the big problems with the AYA group, as far as I understand, is along with their lack of desire to reconnect with the treating hospital once they've finished their treatment. Often they tend to shy away from having a regular GP. Does that have an impact on your program if the young AYA survivors don't have a regular GP? How do you accommodate that?
Yeah, so as part of our app, so one section is like the pain and symptoms tracker. So similarly to like the mental health thing, there's going to be a pop-up which, you know, directs you to services. And we've thought about the fact that maybe they don't have a regular GP, they don't know like who the GPs in the area are. So what we've designed this app to be is essentially that pop-up will, you know, include, you know, links and resources being like, okay, so in your local area, these are like the different GPs, you know, these are like their numbers and how you can contact them.
I might go next. Well done, everybody. I'd like to understand a bit more about what you think the core purpose of your symptom tracker is in this population. And is it about identifying some of the physical consequences of the treatment? Is it trying to identify symptoms of recurrence, or and because these are complicated things to develop, and I'd just like to understand a little bit more about what the core function of that symptom tracker is.
Yeah, of course. So the main function of our symptom tracker is we have some built-in symptoms that are already in the system, in the app, and they can set daily reminders so that there is a pop-up that has a checklist of symptoms, and these cancer survivors are able to look through them and check off any symptoms that they are experiencing. The reason we've done this is because far too often it is very difficult for people living beyond cancer to identify symptoms that may suggest there's something that they do need to consult with a health practitioner about, and they would obviously be very concerned and very worried for a relapse of the cancer. So that's why we've had this symptom tracker that will alert them when there are high-risk symptoms that have been tracked by the user.
So they're quite a complex group from a clinical point of view. And I was just wondering how you'll decide which symptoms and what algorithms you'll have behind that to put into your symptom tracker.
It will be fairly general symptoms that will be, I guess, common to all people across that demographic. We haven't looked at specific cancers in particular because we do want this to be accessible to everybody. So there will be quite general symptoms, but in our app, it also, in that pop-up when there are some certain symptoms that have been noted down, the app will also come up with contacts for further specialists and GPs in the local area, so that if the user is concerned that and they do want to find out a bit more information and want to see some more specialized health practitioners, they can look at the information that is all integrated into our app and get in touch with the appropriate professionals that they believe that they want to see in regards to certain symptoms that they're experiencing.
I might just interject. I think Michelle's audio might not be working, but she sent her question through to me in the chat, so I'll just read it out now. So her question is, her question follows up with, if the patient reports symptoms such as poor mental health, high levels of anxiety, is it up to the GP to contact the patient, or the AHA? As we know, if it's up to the AYA, they're less likely to take that action. That was Michelle's question.
So I suppose the function of the app is that we are in part relying on the AYA to take that action themselves through the pop-up, but we do realize there's less a lower likelihood of that happening if rather than compared to say the GP reaching out. So some functionalities we've considered for this app is, for instance, the data can be linked to say a database that you can give access to for your doctor, and if they also notice a trend there, then it will also pop up in their database, and that will also give them the information that they need if they think there's a need to reach out.
Quick question. So tell us about who would be key groups to collaborate with in developing this. Yeah. Who are you thinking that you might work with on this project?
We considered existing AYA organizations such as Red Kite, I believe, and Canteen. These organizations already have a vested interest in bridging the gap between independency in adulthood and pediatrics and earlier models of care. So I think that that's certainly a partnership that we could get behind, though we would be open to any other forms of partnership that could assist in directing our app and our upskilling workshops to all those who would benefit from it.
Great.
Another question from Michelle. So also with the different age ranges with AYAs, how is the information/workshops tailored towards the person? If they're of school leaving age, finances would be appropriate. However, if younger, it might not be appropriate for them.
Yep, so the purpose of our workshops is that we've got them there. It's not essential for, or it's not mandatory for everyone. Those who are needing assistance with financial needs or want some sort of a bit of a revision on workplace or study skills can sign up for them through our website, which has all the events that are upcoming, and they can do so. So especially for our younger audience, since they are not of working age yet or they are not financially independent, the study skills would be something that they would perhaps like to register for, whereas for those of working age and those who are financially independent, we have those financial and workplace skills there for them.
Okay, judges, any final questions? I think there's one in the chat from an audience member. Okay, I might read that one out then. So someone in the chat has said, how long would you foresee patients using this app for after they've completed their active cancer treatment? Is this going to be a lifelong program, or did you have a set time frame in mind?
So essentially our app is more of a tool to aid a patient in self-management. So it's definitely quite viable to see a patient be able to use this app for, I suppose, as long as they need it. If they feel that they are, I suppose at any point after their treatment, they might still feel like they need to rely upon this tool for self-management, and this will always be accessible to them. Should they have use for it. So I guess a simple answer is the time frame is just as long as they feel like they need this tool to support them in their endeavors for.
Okay, last call for questions. All right, no worries. So that concludes all finalists, that concludes all finalist presentations now. Amazing effort from all teams tonight. I'll now put all the judges just into a breakout room to make their decision on the winners of UCCC. While we do that, for all the finalists and any participants of UCCC 2020 this year, who might be in the audience, we do really appreciate your feedback. And if you could, while the judges make their decision, we'd love it if you could take our evaluation survey. We'll also send the link to the chat. Otherwise, we'll give the judges maybe 5 to 10 minutes and we'll be back with the decision.
Okay, welcome back, judges. Everyone is anxiously awaiting to hear who the winner of UCCC 2020 will be. So without further ado, I'll now hand it over to Michael and John to give some general feedback on each of our winning teams and to announce who the winners of UCCC 2020 will be.
Thanks very much. Thanks, Osha. And I just want to say that this, it was very difficult, but we want to, all of the judges, congratulate everyone who's been involved in this process. It's been a delight to be involved with UCCC and to be exposed to this. You know, we're really so excited that there's been so many teams, so many terrific submissions, and we've really enjoyed the evening and hearing from all of the 5 teams. I think one of the things that we said as the judges just in the breakout room was we're really impressed with the quality of the presentations. Every one of the teams had a really great understanding of the issues that survivors experience, had really thought deeply about the issues and how best to develop a model of care to better meet the needs of survivors and lead to better outcomes. So every one of your presentations was terrific. You had a really in-depth understanding of the issues, had come up with some really innovative ideas. Just wanted to say that every one of them was terrific. And it was a very difficult process, but I'm going to hand over to John, who will talk us through the top 3 positions. But thank you very much, everyone.
Thank you, Michael. Yeah, again, just to reiterate, we were very impressed by all 5, and you could tell we'd spent rather a long time deliberating. So congratulations to you all. So I'm going to present this in reverse order. So the 3rd place team, I'm pleased to say, is the CanCare team. We like the clear focus on the needs of the AYA population and the sort of cute garden reward system and the tailored workshop program. So congratulations to the CanCare team. In 2nd place, we're awarding that to the Transfer of Trust team. Again, we were impressed by the overall model of care, the handover model. We like the fact that you had integrated a number of existing resources and validated measures into your model. So you thought very hard, you identified a lot of opportunities to build on existing resources. And so now I get to the final winners of this award, and I'm pleased to announce that it is the Climbing Out of Cancer team who won this. We thought this was a very well designed and well integrated model. We liked the focus around the broad issues of cancer survivors, including the financial hardship issues, and overall it was a very well considered and well designed program. So congratulations to all 3 teams, and we look forward to engaging with both the 1st and 2nd place teams through as part of the prizes. So well done to you all.
Thank you. Thank you, John. And again, from the UCCC team, I want to extend our gratitude for all of the teams and the amazing work they put into tonight. Congratulations again, Climbing Out of Cancer, Transfer of Trust and CanCare. All finalists will receive their certificates in the next day or so, and we'll also send 1st and 2nd place an email with further details on the organisation of their internship. So on behalf of the UCCC team, I would really like to extend our gratitude towards the guest judges that have taken their time out of their busy schedules to be here tonight and to support the UCCC team as we developed the case file and tonight's event. And if anyone has any further questions, please don't hesitate to contact us via the email uccc@achsc.org.au or find us on Facebook, where we are looking forward to welcoming you all back next year for UCCC 2021.
Thanks, everyone.
Thank you. Congratulations.
Yeah, well done.
Thank you so much.
Thank you.
Thank you.
Thank you.
Congratulations, everyone. Great job.